So I am Dr. Mariana Evans. I'm dual specialist in orthodontics and periodontics. I'm also founder of Infinity Dental Specialists, interdisciplinary practice focusing on orthodontics, periodontics, airway, and minimally invasive dentistry.
Hi, I'm Dr. Julian Conejo. I'm a dentist and part of the team of specialists here at Infinity. And I've been working always on the area of prosthodontics and aesthetic dentistry. So I'm very happy to be here today with Dr. Evans and discuss some exciting topics.
So Julian, it has been about 3 months since you joined Infinity Dental Specialist. It has been such an honor to collaborate and work with you and see how you transform our patients' smiles. I have followed you on Instagram, on Facebook. We have been friends for a very long time. And I am just fascinated with all the minimally invasive restorations that you can offer today to the patients and all the new developments in dentistry that you are implementing now at Infinity Dental Specialists. And it has been very cool for me. Like, I haven't been really prepping teeth or doing any restoration since I was in dental school. I graduated 20 years ago. To sneak peek behind your back and see how the magic happens in your hands. So the question that I have for you, because I think you talk about this a lot in your lectures on Instagram, and when you treatment plan some cases with me, as well as discuss the treatment plans with the patients, you always bring up a concept of additive dentistry.
Yeah.
And I don't often hear this concept in lectures. I know this is maybe not the most new concept, but it's very important concept that we really focus on here in our practice when it comes to minimally invasive restorations or minimal restorations, minimal dentistry that we can offer for our patients. Can you elaborate a little bit of what does it mean? What does it mean, additive dentistry? Because not a lot of, even, I don't know, dentists, but definitely patients understand what exactly it means.
Sure, absolutely. Even when I was receiving my training as a prosthodontist, right, a specialist doing fixed dental prosthesis, let's call them the traditional crown and bridge work, it was always in my head that I'm trying to restore a patient's health, teeth, bite, but I'm grinding a lot.
You are removing a tooth structure.
Exactly.
To be able to
replace
it, right?
With an artificial material, right? So that was always, in a way, I found that like contradictory. I was, very young student at that time, but that was always in my mind. And then I started to research and started going to Europe to learn about less invasive dentistry. So what is that concept? It's basically restoring what is missing and preserving what is present. So what we can do now is actually make a scan of the teeth and design the part of the tooth that is missing. Let's say in the aesthetic zone, many times we have the incisal edge shorter, it has been worn, and we can create a porcelain veneer that is very thin, and it's actually giving the patient back the ideal length of their anterior teeth for aesthetics, for better phonetics, without going and prepping the tooth for a full crown. That removes a lot of tooth structure, right? So that's one very basic and common example.
So a lot of patients understand, oh, I need a crown, I need a filling. But what is important for them to understand, so every time that we have to prepare a tooth for a crown, that means that we have to reduce the tooth structure. In other words, to remove the tooth structure. And a lot of times it's a healthy tooth structure, so we can add the minimal thickness of the artificial material that the crown is made out, or the minimal thickness of the filling, right, that will be replacing the tooth that can last. So that minimal thickness of that artificial material requires a removal of some of the healthy tooth structure, right? So that's exactly what you're talking about. Now we have the technology where we can add additive, right? Add the missing part of the tooth without removing too much of the tooth structure or removing it at all. So the second question that I have, this is fascinating because that's not what I learned in the dental school. In the dental school, I learned that you have to prep the tooth, whether you need to do a crown or whether you need to do a filling. So the question becomes, what is the requirement for this minimal restorations? And sometimes when I think about the very minimal, thin, or very short see-through restorations, I always question, is it going to last? So what is the clinical requirement for that restoration to actually be possible, and also for that restoration to be durable, so the patient doesn't chip it off, so, and it doesn't have to be replaced for years?
So I think it's a combination of two things, right? We need to make sure that we always respect the minimal thickness requirement of the material that we're choosing. Each manufacturer gives us a very clear guideline. My material needs to be milled at least at 0.5, for example. So we need to keep that in mind. But also, it is extremely important that the teeth are in a correct position. Once the teeth are in a correct position, we're going to have a better occlusion or a better bite, right? Like we commonly know it. So once the forces are transmitted to the opposing dentition in a proper direction,
Axially.
Exactly, not laterally, but more actually following the actual root axis of the tooth, then these restorations that are thinner but maintaining the minimal thickness with a good occlusion, that's where things not only look nice but also stand the time, the forces, and can be successful through many years. So what happens sometimes? Clinicians are in a position that is very tricky. They want to do the adhesive dentistry procedure, but the teeth are not in the correct position. If you force it and you go that way, you're going to have chippings, you're going to have fractures, you're going to have debonding or decementation of these less invasive restorations, because we're running away from the crown, that it's mechanically, let's say, maintaining the tooth due to all these reduction that we already talked. So the position of the teeth being beneficial is what makes this very successful.
So in our practice, we have been focusing is setting a proper bite for longevity. Whenever possible, I try to set the dentition orthodontically to avoid restorations, not only to set for minimally invasive restorations, but I try to help the patients avoid restorations when they can be avoided. And obviously, when we can't avoid them, when the patient has a severe wear or has a crown that needs to be replaced that was actually made to the malfunctioning bite, and once we correct the bite, then that crown would require replacement for some cases, or the crown didn't last because the patient was biting off axis, and then the cement that was holding the crown or the filling was leaking. And a lot of times these patients come with failing restorations and they have to have these restorations replaced. So we have been really focusing on setting a good foundation for the restorative dentist to be able to replace the teeth with restorations that can last. And now what we are talking about is additive concept, additive dentistry, where not only we can set up the patients for lasting restorations, but actually to set up for additive restorations, where the dentist, you don't need to remove too much tooth structure, just minimal, right? So this is fascinating. This is something that we really need to implement more and more for every patient. And the other question that I have for you, the technologies, and I know that you have done a lot of research in this field related to adhesive dentistry, to bonding. Adhesive dentistry is basically the glues that are used for these minimal invasive restorations. And I know there are so many innovations and research being done by you, Dr. Blatz, at the University of Pennsylvania in particular. And I want to learn a little bit more. How does this adhesive dentistry, innovations in adhesive dentistry, affect how we prep the teeth today for those minimally invasive restorations?
Yeah, sure. So as I said, now with the advances in the strength on how we can bond the material to the tooth, whether it's a composite, which that would be a direct restoration, that we do it there, right there in the chair, or an indirect restoration that we make an impression. Nowadays it's a scan, and then we design that restoration in a software, and it's fabricated from porcelain material most of the time. The importance is how good we can bond that to the tooth, right? And nowadays we can bond very well to both the enamel, that is the outside part of the tooth, but lately much better to the dentin, which is the layer that is inside the enamel. Years ago, the bond strength to dentin was always weaker and less strong than bonding to enamel. And this is a great advancement because many times we have patients with severe wear because of a malposition of the teeth, inocclusion, or
compromised airway is predisposing patients to severe parafunctional activity as well. And basically they have exposed dentin, right?
Exactly. So the exposed dentin could be also due to acids from the stomach in the mouth, acid reflux, or because we ingest many acidic beverages like carbonated sodas, like energy drinks and things like this. So the nice thing is that now we can be fully additive, making pretty much the cleaning of the teeth, scanning the teeth, and designing these partial coverage restorations that will protect what is present, but we're not drilling, weakening the tooth. And now we can bond very strongly to both enamel and dentin. Many of the work that I'm doing, it's not only restoring the aesthetics, right, with the veneers, that's a lot of what I do, but it's also restoring these patients that have suffered from wear of their posterior teeth, of their molars and premolars. And now we can restore the bite, we can restore the vertical dimension. So even their lower third of the face looks rejuvenated, looks much better. So I would say that how well we can bond and the advancements of the materials are very important for us to solve these issues, whether they are in enamel and in dentin.
That's incredible. Today, many patients are traveling to us from all over the country and also all over the world to receive some dental services such as skeletal expansion with MARPE, periodontal regenerative surgery. And today with Dr. Conejo's advanced minimal invasive dentistry and the digital lab that he built in our practice, we can also offer restorations that can be done the same day that when the patient is getting the braces off. So this is a very big service for patients that are coming to us from a long distance. where they not only need to have orthodontic services, periodontal services, but also some major restorative services or minimally invasive restorative services. So these patients can walk out with the teeth when they are missing teeth and the braces are removed. They can walk out with retainers made same day, within an hour of finishing the orthodontic treatment and removing orthodontic appliances. The same comes to inlays or crowns that can be now made at Infinity Dental Specialists the same day. So I would like Dr. Conejo for you to share with our patients what exactly can be done without sending out to the lab. What can we do now with restorative services for our patients in one day, same day?
Sure. So since July of this year, we started building this in-office digital laboratory. And it's great because as the patient is going through the orthodontic treatment and you are near to finish, we are able to collaborate together and see the aesthetic final touches, right?
Final tuning, yes.
Final tuning, exactly. And nowadays we have, with the use of the intraoral scanner, we have also two methods of manufacturing these indirect restorations. We have acquired a 3D printing system, which gives us the possibility to 3D print in just a few minutes provisional restorations. And many times you have a case that we have already a patient with an implant and we are doing the adjustment of the neighbor teeth and we want to have a perfect provisional. So it guides you to finishing the orthodontics, right? I've been doing these provisionals in the same appointment and that way the patient time is streamlined. It's really used and we can advance.
And you can design it without the dental technician, right?
Exactly. So with
How do you design it?
Yeah, with the intraoral scan that we take, we have design software here that we design the restoration in a few minutes. And then we move to the fabrication, which we could be 3D printed, as I said, for these provisionals that are very durable, very aesthetic. Also, as you were saying, you're printing now the retainers immediately after
mouse
bonding.
guards. And also splints, night guards.
Exactly. And also we acquire the possibility of milling definitive restorations here in office. So whenever we have a patient that needs a new crown and you don't want to be coming back in 3 weeks and having a provisional restoration for 2 or 3 weeks like the traditional analog method, right? Usually those provisionals are more prone to get loose and de-cement. We can make the scan and do the fabrication of the restoration. And in an hour and a half, the patient can walk out with the final restoration. That also, just to finish here, that also has a great advantage that the tooth suffers less post-operative sensitivity. Because when we have a provisional, there's always certain leakage, right? And when we have cold beverages or hot beverages, the tooth suffers during this time of provisionalization. Now we can reduce that risk when we go for same-day restorations.
And for me as an orthodontist, this is a very important concept and protocol for, obviously not for all of the situations, but for the situations where there is a high risk of the tooth shifting, especially in the aesthetic zone.
Totally.
And you want to lock the position of the teeth prior to fabricating retainer, we can have that final restoration for the patient, considering that they have good oral care and good hygiene and don't have gingival inflammation. The day that we remove the braces, all of these factors always are in consideration. So for these patients to make that final restoration the same day as we remove the orthodontic appliances and make them that final retainer the same day is a very big service for the patient.
Yeah, absolutely. And actually, I've heard it from multiple patients that once they get these anterior restorations, as I said, could be direct or indirect, they feel that their teeth are more stable because they are in contact one with the other.
Yeah. The day that the braces are removed, the teeth still have a very minimal mobility that requires healing period. And that minimal mobility is very critical for patients that have small size teeth or have open contacts between the teeth because they require the restorations. That minimal mobility is enough even if the patient gets a retainer for the teeth to shift just a little tiny bit, and by the time they need that final restoration is not perfect anymore. Or let's say the patient loses the retainer and can get a new retainer for 24 hours, that minimal mobility is a risk of teeth shifting. So locking these slightly mobile teeth with good restorations that allow tight contacts between the teeth and allow the integrity of the arch for those teeth. So those restorations will be great to do the same day, so we can make retainer over them and prevent the risk of teeth shifting.
Yeah. Adding to the advances of our in-office digital laboratory, I wanted to mention that we also have a porcelain furnace, and the use of a porcelain furnace is to make the final aesthetic touches to these anterior restorations. That gives me the possibility to do those modifications to make the exact color matching and be more predictable.
And more natural look to the restoration, gives more natural look.
Totally. Because we don't have to send the case back to the dental technician and spend another 10 days or 15 days to get the work back. We can do that in-house or in office, which is very beneficial. And when we're working with the bigger cases, the cases that require multiple restorations, let's say 8-10 veneers, and we work with high-end dental technicians, they are now able to come here for the day of trying and delivery. And because we have the technology here, they can do the fine tuning and the final touches that same appointment. So these are great advantages for both us as clinicians and for the patients.
So we treat a lot of very complex cases that require interdisciplinary approach, where the patient needs to address the bite, needs restorations on natural teeth. Some of our patients require orthodontic surgery. Some of our patients require dental implants, periodontal surgery. And now with the technology that we have at Infinity Dental Specialists for diagnostics and digital planning, to have a team approach and to have the team present in one location, in one visit for the patient is extremely, extremely important from the very beginning of orthodontic treatment to also to the very end of getting that orthodontic treatment finished and set up properly for the restorative needs, periodontal needs. Today we have technology where we no longer have to wait to place dental implants when we need to replace missing teeth after orthodontic treatment is completed. With the digital technology that we have today, we can plan the implant placement sometimes prior to orthodontic treatment, and we can even use those dental implants for anchorage to move the teeth in a more precise, accurate way without compromising other teeth that could be used for anchorage or have been used for anchorage in the past. And in many cases, we can even place dental implants during orthodontic treatment. So by the time the orthodontic tooth movement is completed, we can have those implants healed and ready to be restored even the same day that we remove the braces if the patient is traveling from far or the patient wants to have these restorations done the same day. Or sometimes those restorations are done shortly before removing the bracket, so we can finish and fine-tune the tooth position and close all the open contacts between the teeth. So I would like to talk a little bit about the role of the restorative dentist in finishing or planning the orthodontic cases, because without the team approach, without that restorative professional eye, is not always easy for me as an orthodontist to understand where would that optimal final position of the tooth will be. Not the tooth that doesn't need the restoration, but the tooth that actually needs the restoration. To have that team approach to planning is very, very critical. So I would like to have Dr. Julian comment on the digital technology that now we have to achieve this planning with the latest digital tools that we have and design that final smile for the patient with the digital protocol.
Sure. So in order to be successful with aesthetic restorative dentistry, we want to make sure that we start the restorative treatment with the end in mind. We want to know exactly where the teeth should be, where the restoration should be. And as we incorporate more digital technologies to this part of dentistry, treatment planning, we always now start facially driven. So we start taking portrait photos, 2D or 3D images. Then we combine the CBCT that you've been using for many years, right? Which is the three-dimensional image of the bone. And we can see the support that those teeth have, or see the thickness of that bone when we're planning implants. We also incorporate the intraoral scans that give us the initial condition of the teeth. So with these pictures, CBCT, and intraoral scans, we put all those together, and that's what I like to call the digital clone. It's like the clone of our patient. And here we start doing a digital wax-up, making sure that we understand where is the patient's facial midline, the interpupillary line, basic anatomical structures that guide us to make this digital plan. Once we have this digital plan, then I'm able now to discuss that with Dr. Evans here. And in many cases, before jumping into, let's say, veneers, the patient might have a gummy smile, right? A high smile that shows more than ideal amount of gum, right? So with this plan, with this digital clone, not only helps us for the patients that are seeking veneers or improvement on their teeth, but also in these other situations. You want to talk a little bit about how this digital wax-up also guides you on the periodontal procedures.
So for me, what was really helpful working together with you over this last few months since you joined us was finishing my cases. It's so helpful to have a restorative professional next to me, helping me fine-tuning final position of the teeth that need to have either restorations or gingivectomy, and not all of them will need restorations, but just this final touch of orthodontic tooth movement is impossible to perfection without a restorative consultation. For the majority of our patients that come from local dentists, very often I have to send the patients back to clear them for removal of the braces, to make sure that I put the teeth in a proper position. And for some of the patients that come from far that are going to be treated with Dr. Julian, it's really, really special to have him help me finish them working together at the same time without having patients schedule additional consultations and taking time from work to get this fine-tuning, fine detail completed. The other thing that I wanted just to talk about digital planning is this gummy smile that he was talking about. So digital planning is a very important tool for all of the patients, especially interdisciplinary patients. It allows us to plan the final position of the tooth in relationship to the face, to the facial aesthetics, and prior to orthodontic treatment to determine if we can achieve that tooth movement without orthodontic surgery. For some of the patients, unfortunately, the optimal tooth position and the optimal airway health requires orthodontic surgery, and that initial digital planning gives us the answer who will need the surgery and who can avoid the surgery. Another amazing tool that we use digital planning for is to determine the periodontal limitations of tooth movement. Utilizing 3D imaging, minimally invasive imaging with CBCT, we can project the position of the teeth in relationship to the existing bone and soft tissue support, and in some patients that don't have enough bone support or enough soft tissue support, we also can plan for periodontal augmentation with bone grafts, with soft tissue grafts for optimal tooth movement. Some of these patients have too much gingiva, and we can measure utilizing the X-ray and utilizing intraoral scanning the length of the tooth versus the position of the bone around the tooth. And some of these patients will require, as you said, gingivectomy after orthodontic treatment. And we use the same digital technology to 3D print the digital stance to where we measure precisely prior to removing the soft tissue, removing the bone, how much bone and how much soft tissue needs to be removed. And we use that mock-up, that digital stand for the surgery that allows the surgery to be shorter, less invasive, and definitely more precise, right?
Yeah, and what I've really enjoyed during these last months has been that because we do this digital clone, this digital treatment planning session, and let's say I'm analyzing where I would like to have the limit of the new restorations, we've seen that in many cases you're able to do just a gingivectomy, right? Do a less invasive modification of the position of the gums. And what I like about that is that the tissue heals much faster.
With an open papilla, the papilla is not
affected,
compromised, yeah.
And then we can finish the restorative work in a more predictable way as well. Can you compare the traditional crown lengthening with what we're doing now, and what are the benefits that you see?
Yes. So for the patients that require crown lengthening or gingivectomy in the aesthetic zone, I developed a technique where I use internal bevel. Sorry. For the patients that require crown lengthening or gingivectomy in the aesthetic zone, I actually developed a technique, a papilla preservation technique, where I do the incision with internal bevel just on the buccal without compromising and opening the papilla, which lengthens the healing and also sometimes causes inflammation or loss of the papilla. So now we can use a very minimal invasive gingivectomy that is not only flapless, but it also doesn't require sutures. And these patients heal so fast, they can go to work the same day, and they would be ready for the restorative work much sooner. But of course, not everyone is a candidate for this procedure. So the beauty of the digital planning, having the CBCT, the intraoral scan, where we can overlap the X-ray over the tooth position, the pictures of the smile, the beauty of this digital planning is to determine who is a candidate for that minimal invasive gingivectomy, flapless, sutureless gingivectomy or crown lengthening, and who actually does require opening of the flap and not only soft tissue but bone removal.
Yeah.
The other thing that I wanted to talk about is the digital planning for dental implants. In the past, when we plan the implants, often we have to send out the X-ray and send out the intraoral scan for the surgical stent to be fabricated in the lab. Now, with you joining our team, we can do it in the office, right?
Yeah, that's another area that we have implemented digital technologies. And basically, we have the patient get the 3D X-ray, the CBCT, here in the practice. Then we make the intraoral scan, and then in the implant planning software, we can plan the best position for that implant, respecting
for the bite, for the bite.
For the implant in both the bite, the function of that feature crown, but also very importantly, respecting the anatomical structures that we don't want to get too close to, right? Where we can start by marking in the software where the nerve is, for example, or the maxillary sinuses, and then we can optimize that space for a, let's say, longer implant that will be more stable after many, many years. And once we have that digital plan, then we go ahead and 3D print this stent. So when we have the stent, the placement is very precise. And also, as you were saying, when you do the gingivectomy or crown lengthening surgeries, whether it's me, Dr. Vandal, or you, when we're doing these implants with guided technology, the procedure is much faster, but even more controlled and more safer for the patient.
And safer for the patient.
Yeah, so definitely these digital advancements are helping us in all these different areas of interdisciplinary dentistry.
So as you can see, Julian, in our practice, I'm doing a lot of skeletal expansion for adult patients. And a lot of these adult patients need restorative work after they finish orthodontic treatment. A skeletal expansion with MARPE, utilizing guided planning, digital planning, and 3D printed technology is one of the biggest innovations that we have in orthodontics today for adult patients. In the past, for the patients that need skeletal expansion, that have open bites, cross bites, severe malocclusions that cannot be fixed without expansion, they would only be able to do it with the jaw surgery. When the jaw is actually cut into segments, and then we use special devices to expand. So now, with MARPE, we are doing it without surgery, without cutting the bone. And that opens the doors to treat so many patients non-surgically that require orthodontics and expansion. And I hope that a few cases that we have collaborated on, that you notice the benefits of getting the expansion done. And I hope that the expansion that we do for our patient allows you to do those less invasive restorations when they are needed, where we don't have to cut the tooth structure away, right? Or to remove minimal tooth structure away. So can you elaborate a little bit on how important the occlusion is for you to do this minimal invasive dentistry?
Yeah.
And also, how do you see these expansion cases for the restorative setup?
Yeah. Sure. So as restorative dentists, prosthodontists, we are always struggling where we don't have sufficient space. And when we don't have sufficient space, anything that we place into the patient's mouth is more prone to fracture, to fail. What I've been enjoying during these last 4 months working at Infinity and doing this interdisciplinary approach is that I see how the expansion creates that space to align the teeth in an ideal aesthetic and functional position. So after creating the space, the teeth are obviously all of them maintained, placed in an ideal position, and then the amount of dentistry that we need to do is less but more predictable. Why? Because I'm not confronted to patients having like an edge-to-edge bite or a very deep overbite. That those are situations that restoratively we are compromised, right? Those are the ones that cause more problems. And what I've liked is that many of the cases that I've seen going through MARPE, at the end, the ortho is so nice that the only thing I've been doing is suggesting a tooth whitening to the patient, and pretty much no need of invasive dentistry. So I think that's our optimal goal: try to reduce the dentistry and maintain as more healthy tooth structure as possible. And for some cases that without expansion we were having to cut a lot of the tooth, now with the expansion, that gives us the possibility to do these less invasive restorations.
And also, I think for a lot of patients that have these deep bites, in the past I have seen a lot of cases where the patients needed full mouth reconstruction, where every single tooth needed to be restored with a crown, maybe a veneer. Some of the teeth could be restored with veneers to restore the vertical dimension, the height of the bite, right?
Yeah.
So now with this expansion and some new technologies in tooth movement, we can set up the bites where these patients can preserve the natural teeth in a more optimal function. We can center the teeth over the bone so they can receive the axial loading and transfer that axial loading to the facial skeleton, and also to minimize the restorations to less teeth. I think cutting less teeth and removing less tooth structure is the future of dentistry. And this is the goal that every dentist should be aiming for: less dentistry and less restorations, right?
Yeah, I totally agree. And just the last point that I've seen as a big benefit of the patients that go through the MARPE procedure is how more bone they have around the tooth on the frontal surface, on the facial surface. And that's so important from the aesthetic side as well, because those teeth will have less of a risk of having gingival recessions. And once you have a recession, then that will lead into other problems. So I really see that as a great benefit of the MARPE technique.
So it's MARPE, but also it's a tooth movement protocol that we use in our practice, and especially finishing orthodontic tooth movement protocol, where we use, first step is we address the foundation, the jaw size. So we expand the maxilla to the optimal size that it should be. Then step two, we position the teeth to receive axial loading. And then the step three is actually the axial loading of the teeth before the braces are removed. We use special rubber band protocol, special finishing wire protocol to actually load those teeth axially, because what we noticed utilizing CBCT images, that axial loading during finishing stages of orthodontic treatment is thickening the buccal plate. Every single paper on the traditional orthodontics, utilizing braces, aligners, even tooth-supported expanders, shows us that orthodontic tooth movement is a risk for bone dehiscences and fenestration. And what is bone dehiscence and fenestration? Is actually when you move the tooth outside the bony housing of periodontal support, the envelope of periodontal support. So we know it's in every single orthodontic consent that the patient that will undergo orthodontic treatment is at high risk for gingival recession and attachment loss. And we emphasize this to all of our patients, that they have to maintain good hygiene. And we always monitor these patients with x-rays during orthodontic treatment, and a special tooth movement planning and protocol to minimize it. But now with that skeletal expansion, together with the finishing protocol that allows the axial loading of the dentition before the braces are removed, it actually allows the thickening of that buccal plate. So what you see on the CBCT is that the buccal plate is not thinner, as is in the literature after orthodontic treatment, but is thicker because we were able to move the tooth more into the bone, and the bone is being formed during the finishing stages of orthodontic treatment because we load the teeth axially. And that is very, very important part of the today's orthodontic treatment.